Hi everyone, my name is Matt Goebel. I am a senior resident at Bay State Medical Center, and today I'm going to be giving you an ED perspective on cardiac arrest management. Okay, let's get started. I'm going to divide this into two parts today. The first talking about some of the latest techniques and things that we're doing, and the second talking about some more recent literature that's come out. So in terms of techniques, I'm talking about three things. The nurse code leader or the nurse-led code, just a brief mention of ECMO because I know we have a separate talk on that this afternoon, and pulse checks and the use of cardiac echo during cardiac arrest. So let's start by talking about the nurse code leader. You, as the team leader during a cardiac arrest, have a bandwidth problem. There are a lot of things to keep track of besides all the tasks that you're individually asking people to perform. You have to keep track of when the last epi was given, timing for pulse checks, monitoring CPR quality, etc. So you have a bandwidth problem. You are saturated in things to be doing, and you can't step back necessarily and look at the big picture. So using a nurse code leader, you can share that burden with them by offloading a lot of the more algorithmic things so that you as the team leader can be freed up to think about the other things that take advantage of your level of education and your training. So what exactly would you say it is that the nurse code leader does? Well, they're going to call for epi every 5 minutes. They're going to pre-announce a rhythm check 30 seconds before it happens. They're going to call for the rhythm check, and they're going to act as a single point of contact for you as the team leader to receive and assign all tasks. So then what do you do? Well, you're freed up to use your brain. I was recently listening to a very interesting talk on crew resource management by an airline pilot, and he was saying that in a lot of commercial crew configurations, you've got the captain in the left seat, you've got the first officer in the right seat, and sometimes you have a third pilot who's in a seat behind the two that are actually operating the aircraft, and they call that seat the smart seat because that person is not saturated with tasks. They're not looking at checklists. They're not operating the radio and doing anything. They're just standing back and looking at the big picture. So when you are working with a nurse code team leader, you get to sit in the smart seat and apply your brain and all your training and experience to optimize everything else about the code, thinking about the reversible causes. Is this person an ECMO candidate? What else are we going to do for this person? I will only briefly mention ECMO because I think it's very important, because I know we have a separate talk on this, but I think the ARREST trial is very compelling evidence that ECLS is an effective therapy for certain populations in cardiac arrest, and if ECMO can be done pre-hospital in other parts of the world and in some parts of the United States, it can certainly be done within the emergency department where we are. There is an upcoming Dutch study where they're going to be rolling out a nationwide pre-hospital ECMO system starting in 2022, and I think it's going to be very exciting to follow that study as it's being done and the results when they're eventually published. So last, in terms of techniques, let's talk about pulse checks and cardiac echo during cardiac arrest. The first thing we need to come to terms with is that we are all awful at finding pulses. And when I say we, I mean physicians, nurses, techs, paramedics, EMTs, everyone. There are multiple studies that have done a variety of interesting things, either looking at patients while they're in arrest and using an ART line, or echocardiography as the gold standard for whether there is a pulse, or in a more controlled circumstance when people are on cardiac bypass in the OR, having people come in and then take as long as they want to try and determine whether there's a pulse or not, and we're really awful at it. Even when we take as long as we want, the accuracy, to get any degree of accuracy in finding pulses, we seem to need longer than 10 seconds to do it, that we should be allotting ourselves during an arrest. And compounding that problem is this. This is a clip that I took while putting in a groin line during a cardiac arrest. The left side of the screen is lateral, the right side of the screen is medial. The pulsatile vessel is the vein. That non-compressible vessel laterally is the artery. So you may, even when you're saying, oh, we have a good pulse with compressions, that's retrograde flow from compressing the chest. What you're feeling is the vein. So that's adding to this problem. And we're just really bad at finding this. So what's the answer? Well, I'm an emergency doctor, and if the answer isn't ketamine, it's probably ultrasound. So transthoracic echo, right? Let's look at the heart. Let's see what it's doing. Let's directly visualize the ventricles. And we do this a lot. But a transthoracic echo has some problems. It's hard to get good views. You can't optimize the patient position at all. and we're mostly relying on the subxiphoid view, which, depending on habitus and other patient factors, can be very difficult to obtain. It's hard to get the views quickly, and if you are getting the subxiphoid view, sometimes you're messing around for a minute. If you're trying to get a parasternal view, you've got to be quick and wipe off the chest before they restart CPR. There's been some literature that showed that transthoracic echo during cardiac arrest is associated with an increase in the duration of pulse checks or rhythm checks. And we know that that leads to worse patient outcomes. So is using transthoracic echo harmful? I think if you're not doing it correctly, it is. You still need to be very stringent about the duration of your rhythm checks. But an even better alternative than TTE is TEE. Some studies that have done TEE versus TTE for cardiac arrest head-to-head show that it reduces time off the chest. If you are going to be putting your patient on ECMO, it allows you to confirm wire placement prior to dilating and inserting your catheters. It also allows us to optimize CPR. And what I mean by that is seeing whether where we're compressing on the chest is actually compressing the ventricle or not. There are some very interesting case studies that have been published on this, where they show that the end tidal was low when they were doing CPR. They readjusted hand positioning to where they were actually compressing the left ventricle, at where they could see that on TEE, and got big increases in their end tidal CO2 output. It also, both TTE and TEE, allow us to recognize rapidly and treat this idea of pseudo-PEA, being that we may see that the heart is contracting, but we may not be able to feel a pulse because we're really bad at feeling pulses. And so instead of continuing to focus on CPR and other things, we can focus on supporting the blood pressure, trying to increase the cardiac output, and regaining pulses that way, and potentially stopping CPR, because if the ventricle is contracting, adding chest compressions isn't really doing anything. Because again, those pulses that we're feeling during chest compressions are actually retrograde flow through the veins. So wrapping up by talking about some of the latest research and how that's informing my practice. Number one, EKG after arrest, or the ROSK EKG. The problem with the post-ROSK EKG is always false positives. Cardiac arrest is a low flow state, and your EKG afterward is going to be abnormal. So how long do we have to wait before that rate of false positive falls off and flattens out, so we know that what we're looking at is as accurate as it can be? There's a couple studies now that seem to indicate that the answer to that is about 8 minutes. So in my practice now, I'm still getting the immediate post-ROSK EKG. If it doesn't show any significant signs of ischemia or STEMI, then I'm not worrying about that as a cause for the arrest. But if it does, I'm going to be a little less gung-ho about trying to get interventional cardiology involved and activating the cath lab until I repeat that about 8 minutes after ROSK, when I know that the false positive rate falls off quite a bit. Let's wrap up by talking about post-cardiac arrest cooling. I think we all know that the TTM2 trial came out recently, and that it had, again, has rocked the world of post-cardiac arrest care with regard to our utilization of cooling. But there are some things that the authors of the study warn about as being wrong impressions, and me as a researcher also looking at it and listening to some expert discussions on things caution people as takeaways. Some wrong impressions to take away from the TTM2 trial are that cooling doesn't work, we don't need temperature control, or that we only need fever control. And again, these are things that the authors have stated in interviews that they're concerned that people are taking away from the trial. The right impression that you should be focusing on from the TTM2 trial is that 33 versus 37.5 has no difference in outcomes as it was done in the trial. What I mean by that is that cooling was not achieved on these patients until 1 to 3 hours post-arrest. The physiologic studies, the animal studies that were the evidence to go forward with cardiac arrest cooling all looked at immediate cooling, intra-arrest cooling, or pre-arrest cooling. So if you get someone down to hypothermic numbers a few hours after their arrest, it probably doesn't make a difference. Does that mean that there's no role for hypothermia in cardiac arrest care? I don't think we have an answer to that yet. Now, if you're wondering about the fever control only question, the authors have said, stay tuned, that's going to be the outcome of the TTM3 trial. So to summarize what I'm doing in ED now about cardiac arrest and what I'm going to be doing differently from now on based off the literature. One is the nurse-led code, having a nurse code leader who is doing the algorithmic things and keeping track of that stuff during cardiac arrest so that I can free my mind to be looking at the big picture. ECMO is coming. We need to be looking at ways to implement this in department and having early discussions about what are our criteria going to be, who's going to be cannulating, etc. I think that the manual pulse check should be dead. We're probably going to still keep doing it, but I'm not putting a lot of weight on it because I know that I think that I'm good at it, but I know that the literature says that I'm not. And instead, I'm doing echo. TEE, ideally, if it's available, but otherwise TTE, and being very, very stringent about the time that we're allowing ourselves to look at the heart and making sure that we resume CPR in a timely fashion. Less concerned about what my ROSK EKG shows until roughly 8 minutes after ROSK. And when it comes to cooling, I think we need to keep watching this space and stay tuned. I think we don't have a definitive answer for what the cooling in post-arrest care is yet, but I am not routinely going to be cooling patients as of now, unless they're hyperthermic after arrest. Again, my name is Matt. You can see my contact information there, both email and my Twitter handle. Please reach out to me either on social media or via email. I'd love to discuss anything about this presentation with you. The QR code and the short URL there will take you to a Google Doc that has a list of the resources and the references for this talk, both the peer-reviewed stuff as well as the free open access medical education stuff that's talking about these things, as well as a link to a copy of my slides. Thank you.